Well, good morning or good afternoon to all of you with us today. This is Joy Burkhardt. I'm the founder and executive director of 2020 Mom. We're so glad to have about 20 of you with us live so far today for our first presentation in our Innovation Awards webinar series. With me today are a couple of 2020 Moms team members. I'm going to introduce them first. First, I'd like to say hello and have Christinadelaney introduce herself, and then we'll turn it over to Stacey Porter to introduce herself. Christina.
Hey there, everybody. I'm Christinadelaney. I'm a postpartum psychosis survivor and also the founder of Cherished Mom, and I've organized the Innovation Awards this year, and I'm so happy to have everybody here and have Dr. Miller explain the Compass program, and congratulations to them in Northwestern.
Great, thank you. Stacey.
Good morning or good afternoon. This is Stacey Porter, and I am with the 2020 Mom team. Most often, you guys will hear me helping out on the certificate course that we do online with PSI, but I'm also the lead for our volunteer ambassador program, and I've helped out with the Innovation Awards in the past, so I'm just on deck to help as much as I can, and I hope you guys enjoy it. Congratulations to Northwestern as well.
Great, thanks so much. Well, it's my pleasure to get to introduce Dr. Emily Miller, who's presenting the Compass program today. Dr. Miller is an obstetrician and maternal fetal medicine specialist. And for those of you who aren't familiar with that term, it really means treating high-risk pregnancies. So it's always exciting to see that designation tied to maternal mental health and treating these conditions. Dr. Miller also holds a master's in public health. She conducts research in maternal mental health and has dedicated her career to optimizing the treatment of perinatal depression. Collaborating with mental health experts, she's contributed to a chapter on maternal mental health in one of the preeminent obstetric textbooks. We're so grateful for that. Much more work is needed on that front. And she was nominated by the American College of Obstetrics and Gynecologists to their maternal mental health expert work group to develop a consensus statement to guide care for perinatal depression and anxiety and obstetric provider-facing decision support. So glad that you're part of that work. And pertinent to this award today for the Innovation Award Program in Care, she challenged the paradigm of the current obstetric model by creating and implementing a collaborative care model for perinatal depression called Compass, which you'll hear about today. The program trains and empowers obstetricians, so OBGYNs and midwives, or those who deliver babies, to screen and treat. And the program has served over 1,300 women in 2.5 years. Dr. Miller, we're so pleased that you're with us. And before I advance to the next slide to learn a little bit about your team and the work that you've done at Northwestern, we wanted to first start with 2 questions. And I would like to ask you first to tell us a little bit about Northwestern. Where are you based? Where is Northwestern in the state of Illinois, et cetera?
Sure, and thanks again so much for having me. It's great to get to talk with you again, Joy, and just such a wonderful opportunity, not just to celebrate, what my colleagues and our group has been able to accomplish, but really what I think is an important implementation advancement for perinatal mental health. So, Northwestern is a wonderful university setting. We are on the downtown medical campus, which is in Chicago. Northwestern Memorial Hospital is kind of the broader medical facility, and then the Prentice Women's Hospital is the birthing hospital that is associated. Prentice is a pretty special place. It's a very busy labor and delivery unit. We deliver around 12,500 women every year, and we have a robust OBGYN residency program, which is great to have the opportunity to train the next generation of providers and have perinatal mental health as a part of their education. We also have really phenomenal perinatal psychiatry and psychology faculty. that I've been able to partner with on Compass. And so it's it's the right setting. It's a busy place, and it's just a great opportunity with wonderful collaborators.
That's great. And thank you for that background. And hopefully those of you who are listening on the line are thinking about, okay, do I have a model like this in my neighborhood, or am I part of this kind of system where this program might be relatively easy, right? This work is always difficult to scale. And I know we'll get to talk about scalability soon, but it's nice to kind of tee up the environment before we jump into the details. I also would love to have you, Dr. Miller, speak a little bit about collaborative care. I think for many of us and those on the line, we hear that buzzword a little bit, and we know it's maybe tied to Medicare, but talk to us a little bit about this general concept of collaborative care and what does that mean? What does that mean?
Right, and it's a great question. Actually, when I wrote this grant, I had heard those buzzwords and kind of wrote it, and I don't think I really understood what it was until I was doing it. So don't do it that way would be my advice. But it's a health systems approach to how we deliver mental health care, and that it's a very robust, solid evidence-based as a both effective and cost-effective modality for depression treatment embedded within primary care. There have been over 80 randomized trials, kind of the gold standard in evidence-based medicine, using this health system, showing that it improves depressive symptoms, increases the chance of remission in individuals in primary care settings with depression. I think also really cool is that in some of these randomized trials, it improves other somatic health outcomes. So for example, in individuals with diabetes, some of their metrics of diabetes control are improved after implementation of collaborative care. And so that kind of proves something that should be self-evident from the get-go, but that if you treat the entire individual, their physical and their mental health together, you can make them better. So intuitive, but in medicine, sometimes we require a lot of trials to prove that to ourselves. Perinatal collaborative care is less robustly studied, as unfortunately a lot of things in the perinatal context are. There have been 2 randomized trials of collaborative care in obstetric offices, and they have been shown the same kind of outcomes with improvements in depressive symptomatology. But I think what's been missing is, okay, great, in a randomized setting with a relatively homogenized group of people and a robust infrastructure for how to monitor and what we're doing and algorithms, et cetera, when we implement this in kind of the real world, what happens and does it work just as well? And so that's kind of where Compass comes into play.
Oh, that's fantastic. I think all of us are cheering and clapping, like, thank you for that overview. I'm actually going to use that as just a quick segue to remind folks that if you do have questions or comments throughout the webinar, you're welcome to use the question feature in the GoToWebinar control panel. It's that long box that usually shows up on the right side of your computer. If you can't see it, you might just toggle and see if you can find it behind one of your programs. Again, you can use that question feature. Don't be shy. We've got an hour together and want to hear feedback from you and any questions along the way. Well, I really appreciate that overview of the collaborative care model, and also just recognizing when we talk about primary care, we're really talking about obstetric care, aren't we, in the context of perinatal and maternal mental health. Dr. Miller, is that any thoughts on that and really kind of lifting up the obstetrician as the primary care provider?
Yeah, I think that's a really important comment. And I think there's OBGYNs tend to toggle between being primary care doctors and seeing themselves as such, and then seeing themselves as specialists in pregnancy. I think collaborative care is really taking the expertise that obstetricians have, but then empowering them with a system behind them that's going to help them perform the screening, the treatment, the stepped care, kind of all of the steps in the perinatal depression care cascade. Because even our best OBs that see themselves as, champions of perinatal mental health, it's really hard to do this without a system behind you. And so I think that's where collaborative care is really advantageous.
Excellent. Well, thank you. Let's move on to the next slide. It's a great segue to talk about your team and the system behind you. Before we do that, though, we can just explain here that what COMPASS stands for is a collaborative care model for perinatal depression support services. And here we are with Dr. Miller. Here's your team. Do you want to walk us through this slide, Dr. Miller?
Yeah, so these are the phenomenal humans that I get to work with on a day-to-day basis, and I get to sit here and talk with you, Joy, about the program, but the COMPASS itself, and I think the whole mantra of collaborative care is really that none of us individually are as smart as all of us together, and so this is a team sport for sure, and so these are the group of people that are involved. So, I'm the program director. I kind of run the day-to-day stuff. I certainly provide the obstetrics input on, how we think about some of the physiology in pregnancy, how some of the recommendations might adapt into our obstetric infrastructure. Dr. Gallen is a psychologist. She's our clinical liaison. What I found in an academic setting, and I'm sure this is in pretty much every setting, is, having two different academic departments start to work together in such synergy as is required with collaborative care is challenging. And so Dr. Gallen helps with everything, but certainly kind of facilitating some of the complex dynamics between administration and the department. And she also provides a wealth of psychology resources. The hub of the system is the care coordinators, are often called the care managers. They're really the linchpin of an entire collaborative care program. Rebecca and Lauren are two just absolutely wonderful women that bring compassion, expertise, professionalism, and their role is really to perform the initial intake with patients, to go over their symptoms, review the care plan, come to our weekly meetings, bring up issues, and then facilitate kind of changes in care plans, that communication back to both the obstetrician and the patient herself. So they're really doing all of the heavy lifting and are just a wonderful asset to the program. Our psychiatrists, the two current psychiatrists are Aparna Chatterjee and Louisa Alushoga. They are our perinatal mental health fellows here at Northwestern. So one of the things I'm really proud about with COMPASS is that not only are we delivering, cutting edge evidence-based care, but we're also training the next generation of women's healthcare providers. And so we have the women's mental health fellows fill the role of the psychiatrists in our model to enable their education, but also certainly embodying their expertise. And then our therapist, who delivers the majority of the psychotherapy for women in our program, is Rachel Ostroff. I don't have their pictures up there, but Kathy Wisner and Bill Grobman are my academic mentors. Both of them are internationally renowned experts in perinatal psychiatry and maternal fetal medicine, respectively. And then our data management team, because a big part of COMPASS has been not only can we deliver this care, but then starting to compile the data on this implementation project and disseminating it to say, is collaborative care effective in randomized trials, but is it also effective in implementation studies? So awesome group of people that I'm just so grateful for.
Excellent. That's great. I know folks will have some questions about that, but we'll get through how you received the initial funding and sort of ongoing sort of stability and funding of the program here in just a bit, but very helpful to see your team. Let's go ahead and jump into some of the data sets on your program. Dr. Miller?
Yeah, so this slide's really about the timeline, and I think what you can see in the figure on the bottom right-hand side of the slide is our referrals. When we started, I wasn't really sure if people would understand collaborative care or refer to a collaborative care program, or kind of what direction this would go. And this referral slide is to kind of point out, if you build it, they will come. And pretty much instantly we were getting 30 to 60 referrals per month, and that has held steady through the 2.5 years that we have been clinically active. And so I think it's just an incredible testament to the existing need and to how eager obstetricians and midwives are to have a system in which to know that their patients are getting comprehensive care. And you can advance a little bit, Joy.
There we go.
Awesome. So this was kind of one of the questions had been, what's the timeline of when this started? And I think another point I want to make is, you can see on the left-hand side with the green box around it is when our funding was received. And I'll talk in a few minutes about who our funder is. And there's a big gap between when we had our notice of award and funding was given and when, in the purple box, when Compass was implemented. And a lot of stuff happened in between. And I think the message for people who might be, just as impatient as I am to get something going and off the ground when you have the resources to do so, is it takes a lot of time and a lot of education to get folks up to speed on collaborative care. And so we spent about 6 months doing a lot of work with our administrators, engaging stakeholders, reviewing with our legal team how we were going to handle sensitive mental health information, thinking through how we were going to care for women who had, mental health carve-outs, or who didn't have insurance that aligned with that was accepted by our psychiatrist, and then going to each of the divisions that we were supporting to say, this is what collaborative care is, and maybe in the past you would refer out and other people would manage, for example, postpartum depression, but we're asking you to do more. We're asking you to partner with us, and our team will support you, but we want you to take the lead on this in terms of the prescribing, in terms of we need you to screen, and we'll help you from there. So I think the kind of message for this part is, it is totally worth taking the time to line things up and do it right before you launch, so that when a program launches, it can really fly, as opposed to just starting something and then kind of patching it up as you go, because it's certainly, collaborative care is a complicated system. And Joy, if you could advance one more. I think the other piece that I wanted to mention in terms of what a timeline might look like is that even that launch you're not done there. And so even though we had implemented the program, one of the things that has become abundantly clear to me is the need for ongoing education. And so, we created all kinds of algorithms and protocols and how we wanted our obstetricians and Compass to kind of co-align our care, so we were all working off the same playlist. But it certainly requires kind of continual reinforcement. And so a part of the program is going back to each of the participating clinics every 3 to 6 months to say, to celebrate the successes, but then also to point out opportunities where we can all continue to improve.
That's great. Before we move off the slide, let's spend a little time on funding and what it took to initially launch this program, and then we'll talk about training as well. Why don't we just talk about funding?
Right. So this all happened very fortuitously. There's a wonderful philanthropic organization that is affiliated with Prentice Women's Hospital called the Friends of Prentice, and it is it's a 501c3, and they are dedicated to improving both research and care programs that affect the women and the arc of women's lives in the Chicagoland area. So they had released an RFA saying, if anyone can think of a gap in health services that impacts women and an opportunity to build an intervention that is sustainable long-term, that's who we're targeting. And so, like I had said, I had heard the words collaborative care, and I knew there were certainly gaps in our health systems approach to perinatal mental health care. So I, wrote this grant, and they graciously awarded us kind of the startup funds And I think startup funds are really important for collaborative care, just to bring everyone to the table. We had been having a lot of the same conversations on the importance and how access was limited and we needed to do something. But when you come with a big check kind of at the center of the table, a lot of people gather around. And so it really kind of helped fuel moving things forward. It also helped us hire our initial staff members, develop our database, and really kind of start to put our educational and treatment framework together.
That's great. Do you mind sharing roughly, if need be, what was the initial funding that you received, and how long does it provide coverage for the startup program? Is it a couple of years or beyond that?
Right. Yeah. So the grant was for 3 years, and it was the initial award was $840,000. That's a lot of money, and I want to kind of couch it with it doesn't. I think there are a lot of advances now. What I don't want people on the webinar to take home is like, I need that much money to start. I think this was the first time we had implemented it, and we kind of budgeted for access to all these services to require payment. But we're now learning, and there's a lot of legislation that's been passed that allows you to bill for collaborative care now. And so I think that 3 years ago, that's exactly how much I thought this would take. Now, I don't think that's the case. I think there needs to be a bolus of something to bring people together. But the goal with Compass is that this will be a budget neutral program. I think the other piece that's important with our budget is we're doing a lot of research with this. We have a huge database where we're collecting for each patient 250 different variables. We're following them for a year postpartum, like a robust amount of information, because not only do we want to deliver care, but we want to prove that delivering this care is effective, because we don't want to be implementing perinatal collaborative care if it's not shown to improve the lives of the women we're serving.
Yep. So your program is really going to help the rest of us make the case through your research and really lifting up the model that works. This is the recipe, and in the end, right, hoping to show that it's really evidence-based.
Exactly.
That's
and hopefully
great.
if we can, through these data, publish that this is something that really benefits women, then insurance companies will follow suit and more will sign on to funding collaborative care in the perinatal context.
That's great. And we'll talk a little bit about, you had mentioned legislation that was passed, and I think we're talking about Medicaid funding, and perhaps it's national, perhaps it's state-based, but we'll talk about that in the sustainability portion of our conversation. Before we jump into, there's a couple good things that you've already touched on this slide, but before we jump into the data and also the treatment algorithm, I'd love for you to talk a little bit about training. And I'd like to tee it up by mentioning, what we're seeing, and those of you who are on social media this weekend, you may have seen that there was a mom who went to her obstetrician in Alabama, and one of our biggest, concerns, and would love for you to hit on this, Dr. Miller, and how you cover this in training, is just we find that obstetricians just don't know what they don't know, and even psychiatrists don't know what they don't know relative to the difference between psychosis and intrusive thoughts, right? It's sort of this big problem area that is a black, bit of a black hole in this white space in terms of understanding that has really, I think, been a hang up for progress in a lot of ways, and why women don't speak up. Would you talk about training? Well, what kind of training do you provide to your obstetricians to help them have this sort of baseline, but also know that you're there for the difficult cases?
Yeah, so we, a part of implementation and a part of that initial 6 months of going to these offices was saying, our expectation at this point is that, you will take the lead on quote unquote basic perinatal depression and anxiety, and that, they will screen, we will, we will support them with the algorithms on kind of what to do with that information, and if pharmacotherapy is the is what's collectively the best treatment option, how to start, how to dose increase. We will help with the monitoring so that we are tracking women more often than necessarily how often they're coming to their OB's office. So we do that remotely. And so a lot of education on kind of the structure and things that I would say many obstetricians already know, just the basics of how to screen and how to start treatment. I think some highlights in the education that I think are a little bit more nuanced than what many obstetricians get in our training is, starting, for example, and I'm targeting pharmacotherapy because it's often what is really in the hands of the obstetrician, right? Starting 50 milligrams of sertraline is a good start, but that may not be the end point. And so recognizing that, it's actually the minority of women that respond to such a small dose, and understanding the pharmacokinetics of SSRI metabolism. So we did a lot of education there, was really the start point. I think as we go back each 3 months, we've had good opportunities that are more case-based to do ongoing education. So you brought up the great example of differentiating postpartum psychosis and postpartum OCD, for example. And we have had that come up. We probably do 4 or 5 times a year where the OB office will call us and say, we're going to send this woman to the ER, I think, because she called with these, these thoughts or what have you. And we can do some targeted feedback there, both in the moment, and then when I go to the OB's office to kind of continue to re-educate, then say, let's talk about this and what might the differential be. So I think there's, perinatal mental health 101, and then we advance from there.
That's great. And I think you bring up a good point, is that sometimes these are the cases that scare OBs away. You didn't say that, but it's sort of, where do you start so it's not intimidating for obstetricians? And then knowing that there's this lifeline, if you will, to call you if a mom may be suffering from intrusive thoughts or scary thoughts or talking about harming her baby or herself, that you can help mitigate those challenges once that obstetrician calls, which sounds like really a great way to balance this struggle that we see so often. That's great. Let's talk a little bit about the treatment algorithm on the screen, and then we'll pause to see if anyone has questions, because we're covering a lot of good information here. I want to make sure you're engaged and have a chance to raise questions or comments. So let's talk about that algorithm, and then we'll open it up for questions through the chat box.
Yeah, so the algorithm that I listed here is actually just one of 6 different kind of OB-facing educational materials that we developed to make sure everyone was brought up to speed. And I think, we just assumed everyone was starting with kind of no baseline knowledge, because it's always a safe bet. We didn't want to assume folks had experience. And so every office now has these 6 handouts kind of available. They're all electronic in all of their inboxes. They're kind of linked. And this one in particular, I think, is the one that's used the most. And it's really the concept that SSRIs are not one size fits all, and that many women are going to need increasing dosages to achieve remission. And that's our goal, not just sending a prescription, but our goal is this woman doesn't have depressive symptoms any longer. And so this in particular is talking about how to start, how often we're monitoring for mood symptoms, and then how quickly and what dosing interval that we escalate. And then on the bottom are, noting some of the psychoeducation that should occur, regarding if she becomes, agitated or energized, that there might be concern for bipolar disorder, that she should stop and reach out to us, or if she's having some of the side effects of SSRIs that are listed, to reach out to us. So kind of a good resource for OBs to utilize.
Great. Yep. This is good, and I could see us wanting to share this more widely, this sort of recipe, if you will, around what do I do if I want to prescribe. Talk to us about pregnancy and how often you see women on an SSRI during pregnancy, and how you're kind of managing the the risk for just a moment around potential harm to the infant. That OBs are raising concerns about this and often take women off their SSRIs. I know your program addresses that very nicely. Anything you want to share with folks who are listening about that point?
Yeah, I think it's ongoing dissemination of that of the evidence. I think one of the handouts we have in our packet that I can say I still even use when I'm talking to a patient is described pharmacotherapy, and it has 2 columns. One column describes what are the risks with SSRIs in pregnancy and lactation, and it's a very brief list, and we could certainly talk about what those risks are and the evidence behind it. On the right-hand side is what is the risk of untreated depression, and I think that that's the comparison group we have, right? Is that as a clinician for the woman that's in front of me, my decision is, do I let her depression just go on unremitted, or do I treat it? And so I think when we frame it in that way, it really actually alleviates a lot of the obstetrician angst as well as the patient angst around starting a medication, is that, we can't just snap our fingers and make it go away. We have to do something. And so that's the proper comparison group. And I think, unfortunately, a lot of our data that exists in the world is comparing SSRIs to women who aren't even depressed, that obviously aren't on SSRIs because they don't need them. And that's not the comparison that we have in the real world.
That's great. I'm sure there's going to be requests for that packet handout, especially if you use it often yourself. Dr. Miller, maybe we can follow up and make sure that that's posted to the website on 2020mom.org. We'd love to get our hands on that. I want to also, before we move off of this issue of medication treatment, have you grappled yet with the notion of informed consent around these issues? So risk of not treating and risk of treating with SSRIs. Is informed consent been part of your program yet, or something that you might be looking to address further down the road?
And Joy, help me understand. Are you thinking in terms of like
patients? Yeah, patients understanding. Right. Patients kind of being part of their treatment development and signing off to say, yes, I understand the risk of taking these medications during pregnancy or even lactation, and I'm willing to accept them. Is that something that the program has addressed yet? And it's very, very much a new concept, I think, in this space, but something that is we're seeing really garnering some interest and to help mitigate risk even for obstetricians, right?
Right. I mean, I think of it through the lens of shared decision making, is that, I think that handout that I'm alluding to, and it's not groundbreaking, but saying, to a patient, okay, I hesitate a little with the concept of risk acceptance, because I think when we're talking about SSRIs in particular, what we don't say is, are you willing to accept the risks of untreated depression? And so I think it concerns me a little bit to frame it as, are you willing to accept the risks of SSRIs? When either option, there's no risk-free option. It's kind of a balance. And so at least my approach clinically is more of a shared decision-making of, hey, here's the list of what can happen with untreated depression and what I'm worried about. And here are the, very small handful, and I don't mean to totally diminish them, the risks associated with this medication that's been studied really robustly. And so then together we can decide, is psychotherapy appropriate? Is it accessible? Is it something she's able to, does she have the capacity and the support around her to have the time to do that as an alternative, or kind of what approach we're going to take together. So,
great.
But I think it is shared decision making. Yeah, I also think the care manager is a great asset. I talked about them as the linchpin of our whole system, and I think I fully recognize, as a champion of perinatal mental health work and an obstetrician, I recognize that sometimes I ask too much of our OBs, and I recognize that in a 15 or 20-minute visit where you're trying to cover, weight gain in pregnancy, blood pressure, growth of the fetus, fetal movement, precautions around preterm birth, et cetera, like the million things that we charge our obstetricians with covering and educating our patients around. This is a lot, and it takes a lot of time. And so I think having a program like collaborative care program, you can almost offload a lot of that, what should be a very long conversation, because you have a person that has that education and has that framework to have the discussion in more than the 5 minutes that even a devoted obstetrician is going to have.
That's great. Yep, that's what's needed. I think everyone agrees, right? It's too much to ask just the obstetrician to do so much without the system in place. One more question that's come in through the chat box or the question feature in the GoToWebinar control panel. I'm saying that out loud in case others want to add your own question. Is tell us a little bit about the screening tools or tool that you may be using in your program. Are you using the PHQ-9 to Edinburgh? Are you also screening for bipolar disorder before prescribing or monitoring for risk after?
Yeah, great question. So the way an intake works is most women come in with perinatal depression. So all of our obstetricians screen prenatally at least 2 time points, and then postpartum with the PHQ-9. And then we use the PHQ-9 once they're in our system to track their depressive symptomatology. So for women who still are experiencing depression, we will send an electronic PHQ-9 every 2 weeks. And for folks that are in remission, we do it every 4 weeks. And the concept there is to monitor for relapse of symptoms. And so we educate women on, you come to your OB's office, we take your blood pressure. Well, you're going to get an email from us that's kind of taking your mental health blood pressure, as we want to know what your symptoms are doing. And I think a lot of women find it eye-opening because they'll say, I'm doing fine. But then I can reflect back to say, you know what, your PHQ-9 went from a 6 to a 9 to a 12. Like maybe you're not doing as fine as you think you are. And it's a good conversation starter. We also, for anyone that's on SSRIs, have a side effect rating scale just to inform the conversation if we're thinking about dose escalation on how she's tolerating the medication. And then we have recently added G87 in terms of monitoring, because we've certainly anxiety is often comorbid and with depression, and we often find anxiety symptoms will escalate prior to the onset of depression. So it allows us to monitor closer. The question about bipolar is really important. So everyone who comes into our system completes a set of intake screens either in person or by phone, and one of them includes the mood disorder questionnaire. We really try to complete that before prescribing an SSRI. Either the OB does it, or I'd say more often our care manager does it.
Great. That's really helpful. And these are the same tools that are recommended and the GAD-7 or the GAD you had mentioned, Dr. Miller, 7 for anxiety, the PHQ-9, and the MDQ or mood disorder questionnaire for bipolar disorder. So it's really helpful to understand where that all fits in your framework, and it seems to be consistent with where things are headed nationally in recommendations. Good, let's move on to the next slide, and feel free, those of you who have questions at any point, to use that question feature in the GoToWebinar control panel. All right, so evidence of impact and scalability. We talked about this referral grid already, so let me go ahead and pop up the other items for you to talk through, Dr. Miller.
Yeah, so I think in terms of impact, the grid was just to re-anchor to we're in a short amount of time have reached a lot of women. And this is just the referrals, but what we're seeing is around 75% of women that are referred will actually enroll in the collaborative care system. They'll complete the screens and they'll engage to some degree. And when we remember that, in our usual care, that acceptance of some kind of intervention is on the order of around 15%, it's pretty awesome to see that people offered this resource will use it. On the bottom left, you can see the distribution of clinics, and I recognize the algorithms and the numbers on the left-hand side of those bars will mean nothing to anyone that doesn't work at Northwestern. But I've put the orange rectangle around 2 clinics, and this has been really important to me. about these two clinics are clinics of women whose prenatal care is supported by Medicaid insurance. These clinics serve remarkably under-resourced women that in the past have had little to no access to therapy services. To see a psychiatrist would become almost impossible, even in Chicago, so I can't imagine elsewhere across the United States. And around 10 to 15% of the OBGYN population that is served by Compass gets prenatal care in these clinics. But around 20 to 25% of referrals to Compass come from these clinics. And so to me, one of my hopes is that Compass not only is going to improve clinical outcomes for all women, but it might also reduce some of the disparities in mental health care that's experienced by this most vulnerable population. I think whenever we're doing implementation work, we need to be attentive to not only, how the program might be impacting the overall population, but some programs can actually exacerbate disparities, and that's certainly not what we're all here to do. So we're particularly attentive to what the impact is in terms of racial ethnic disparities as well as socioeconomic disparities. And then on the right-hand side of the screen is kind of looking at dissemination. So we've had great opportunities to speak about collaborative care. This is an awesome one, but on a webinar supported by the Council on Patient Safety, at the Perinatal Mental Health Conference, at the Society of Maternal Fetal Medicine. We're working on an implementation paper with a bunch of collaborators, kind of what folks are doing around the country, and then kind of putting from soup to nuts, like how do you do this, to put words on paper for people to reference. We're also working with, now it's 9 other medical centers on, sharing our algorithms. I talked to a lot of folks on, hey, here's what we're doing. One of the most valuable things I found when starting this program is I had Dr. Nancy Grote come. She led one of the randomized trials on perinatal collaborative care in Washington, and she's just a phenomenal clinician, educator, colleague. Can't say enough wonderful things about her. And she was willing to come to Northwestern and before we launched, kind of walk through the program with us and helped us identify things that, I certainly hadn't thought about before in terms of, how we might want to adapt our program. So, we're doing that kind of work and are happy to continue to do it to educate folks on how to implement these programs.
Great. Excellent. And want to share before we move off of the Perinatal Mental Health Conference, that green box here on the right corner of the slide that will also be presenting this program as part of our Innovation Awards presentation at the Marseille Society of North America Conference, which is essentially the Perinatal Mental Health Conference coming up this month at UNC Chapel Hill. For those of you who are on the line and will be at that conference, you'll get to hear Dr. Miller present again and have a chance to meet with her in person. So we're glad about that. We will follow up. What I'm making note of as we talk through this is that we would like to share the Safety Action Series webinar with all of you as well. So we'll make sure we follow up for those of you who are listening with a link to that webinar as well, so you can go a little bit deeper on collaborative care. Let's go ahead and advance to the last slide here again before we open it up for Q&A. Is there anything else you want to share as we digest all that you've shared with us already, Dr. Miller, about the team? You had mentioned the care coordinators briefly, and I think you touched on therapy briefly, and that sort of recognizing that sometimes therapy can be a barrier, even though it's evidence-based. Anything else you want to share on this slide before we open it up for Q&A?
No, I just want, the lasting image is really that about a team, is that this isn't, collaborative care certainly isn't any one person can do. The whole nature of it is that it's a group of folks that come together that use shared care plans to care for a population of women. And that's what we've been lucky enough to get to do. And I can't say enough good about what this program has done for our patients, for the culture of incorporating mental health into pregnancy and postpartum care. And I really look forward to answering questions and to kind of working with anyone on the line that wants to talk more about implementation.
Excellent. It's a good segue to talk a little bit about next steps for those who are listening. I'd love to ask you, Dr. Miller, for those, let's just use our imagination for just a minute. I'm going to say, let's imagine that, and we may actually have some of you in these cities, so please chime in if this is the case. Let's say I am in a hospital system in Kansas, and I'm on the line right now, and I really love this model. Or I may be in, let's say, Michigan or Montana. Would you talk to us a little bit, if you were the champion of a program like this in one of those organizations or states, and we will go ahead and name that it's a large hospital system, maybe not tied to a research institution or a university. What would you do next? Would you look for a grant? And it did seem like it was kind of kismet that the grant opportunity kind of fell in your lap in Chicago. But what if that wasn't the case? What would you be doing next?
Yeah, I think the biggest starting point with funding or not is engagement of stakeholders. And I think, like I said, funding is a great way to get stakeholders to the table, but there's certainly other ways of just, documenting gaps, bring to administrators, hey, here's our system and here's on the patient level where things are falling through the cracks, and how, that's not what a health system is designed to do, is to leave women without care. And I tackle my kind of approach to administrators, using that, talking about, gosh, think about the resources. I mean, as an obstetrician, I can't tell you before Compass how long it would take on the phone trying to find a psychiatrist that would specialize in, something unique in the perinatal context, who would see someone that had Medicaid insurance, and, just give examples like that of, the health system is spending inordinate amount of time to link people to care. And so kind of this cost savings there. And then there are, I think the last is, this can be a budget neutral program. There are ways now, and this is rapidly evolving, to bill for all of that effort and care coordination. And so this can be a program that really ultimately doesn't cost a lot of money, but improves health outcomes. And so, I think step one is just bringing stakeholders to the table. And actually that webinar that you mentioned has a lot of kind of how to do that, and things that, we did to start that I think are really helpful.
Great. We're seeing some feedback from an obstetrician in the California area who is much like you, and with regards to her training and based now at UCSF, who's saying this is so incredibly helpful. Thank you so much. So I want to give you a shout out, Amanda. Thanks for sharing that feedback. Let me ask you, Dr. Miller, in terms of billing, let's talk about that for just a moment. You hit on that earlier, mentioning that there was some change in laws. Can you talk a little bit about collaborative care reimbursement and what you are watching? Is that something that's being implemented in most states from what you know, or are we really talking about Illinois so far? How are you going to seek to reimburse for this program once the grant funding ends?
Right. So I think in our perhaps unfortunately still fee-for-service medical model, a lot of the care, if someone does need a psychiatry consult or therapy, is still a billable service. And so that's kind of the usual care and fits under the usual rubric. I think the nuance with collaborative care, and truly the cost of collaborative care, is the care manager or care coordinator piece. And that's the person that, again, is going to devote that extra time to the education around and the shared decision making around treatment, who's going to manage that registry that's going to get really big really fast no matter where you are, to monitor folks' symptoms, that's going to reach out to OB and say and discuss with the whole team, and then back to the obstetrician how we're going to achieve stepped care, what's the next role. that's expensive. That's a person with a decent amount of expertise in that role. But now many commercial insurers, but not all, are covering collaborative care, care manager services. And now I know this is in Illinois specific that Medicaid has come on board and will cover those services. We're just starting the process of billing. We've had the luxury of this grant, and so we're going to do that a little bit more slowly. My hesitation, is that I don't want costs to be prohibitive. And that balance of people with kind of heavy copays or high deductibles, what is that going to look like? And so we're being a little bit, we're a little bit glacier in speed because we have the luxury of this grant. But I think we anticipate that the care managers could fully support themselves with the billing opportunities. And it's time-based billing over the course of a month. That includes kind of all of those care coordination activities.
That's great. And you would say that the others on this map right now that we see, your Compass team, would be able to bill their time for their time just like they would for any other service. It's really this care coordinator piece that is not been reimbursed typically through standard insurance claims, et cetera. Is that what we're hearing you say, Dr. Miller?
Right. Yeah. I think, a psychiatry consult or therapy, the overseeing the whole program is a little bit different, but those that are
right.
that are passionate enough to go through all of this are usually willing to do that just because.
Right, exactly. Like many of us on the line now, right? Because it matters. That's great. A couple additional questions, and I do want to say before we move off this topic of billing, somebody asked also like what kind of legislation's in place in Illinois or others to make this happen. Is that this is really the sweet spot of 2020 Mom, is that we're looking to close gaps and we're looking at legislative policy solutions, practice policy solutions, and lifting up models like this to help those that are in a place to be able to do this work proactively, be able to do it. And so those of you who have questions around legislative policy changes in your states and reimbursement around care coordination, let's stay connected. We certainly, Dr. Miller, want to hear about the Northwestern program, and as you start to bill, what kind of problems you might run into, and again, want to help champion some of that change from the perspective of both mothers suffering and also providers who are struggling to do the right thing. So appreciate that shout out. One thing that came in via question before we wrap up here today is to talk a little bit about how you screen. Do you do paper screens? Are you doing this electronically? You mentioned kind of follow-up at 2 weeks and 4 weeks, and I love that term. I'll say, I'm sure others recognize it too, that term of remission, that depression can potentially come back once you've had even new onset during the perinatal period, and that term remission is really interesting. But do you screen electronically? How do you do that?
Yeah, I think all of the above. We are, we create all kinds of algorithms and how we do things, but ultimately it's a pragmatic program, and we will get the clinical care to people and the screening to people however we can, however is adaptable to them. So in general, the first intake is in person in the obstetrician's office, or that first screen. We really push, and we have, all kinds of EMR signals to our obstetricians for our high-risk women. Please, 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 if they're in your office, get a PHQ-9, so then we know what the data are. But the registry is electronically linked, and so we use REDCap. Many universities have it, but we have an algorithm built in so that it will automatically send the screen via email every 2 weeks. If they don't fill it out, there's reminders every certain period, and then if they don't fill it out after 3 reminders, a note goes to our care coordinator to say so-and-so didn't respond. So kind of some quality checks to make sure that we're reaching out. If they don't respond via email, then we give them a phone call. We can walk through it by phone. So kind of all of the above is the short answer, but try to do a lot of it electronically, recognizing women aren't going to necessarily come into the office frequently to fill things out on paper.
That's great. Really, really good information, REDCap. And I actually hadn't heard it, Joy. I heard that term before, that program before, so it's great to know that that's what REDCap is about. We also have another question that came in about pediatric provider engagement. And is your program looking to engage pediatricians? And if not, why or why not?
Yeah, it's a wonderful question. I think conceptually, absolutely. The challenge is, at least at Northwestern, is more of a logistic one where, this right now targets a cohort of around 3,500 women who deliver each year at 5 specific prenatal offices that then go to, probably 100 different pediatrics offices all over the Chicagoland area that aren't necessarily linked to Northwestern. So it's really conceptually totally on board. The other piece, I'm actually working on a grant right now to partner with some of our neonatologists to embed a collaborative care program within our NICU, because it's obviously a high-risk group of moms. So to take all women and to partner with the neonatologists to actually be managing depression for both postpartum depression as well as co-parental depression.
That's great. Thank you for that information. And I'll also just acknowledge that question just briefly before we wrap up, is that what we found is that it's really helpful to start with obstetricians if you're building a new program like this, collaborative care, or even just developing a screening program. Dr. Miller, you might be able to hit on this, but what we have found is that new onset of these disorders happens almost as frequently during pregnancy as in the postpartum period. And also, we know more and more young childbearing age women are coming into pregnancy with a pre-existing depression or anxiety, which may or may not have been diagnosed, and that the obstetrician is really going to be the first to see that. Right. The research is now also showing, right, the link to preterm birth. So we know moms themselves deserve treatment, but the fact that payers like insurance companies or state Medicaid programs, the fact that they can prevent preterm birth too is, incredible icing on the cake, if you will, to diagnose and treat women properly early, and that obstetricians are in a position to do that. Anything you want to add on that point, Dr. Miller?
No, I think you bring up a good one that, a lot of programs will screen postpartum, but then miss the opportunity to start treatment earlier and to mitigate a lot of the adverse impacts. I think there's also some probably shared pathophysiology, not just with preterm birth, but with gestational diabetes, with preeclampsia. I think there's a lot we could do if we could screen and treat women earlier. So just absolutely underscore that point.
Great. Well, we're going to do two things before I announce the upcoming webinars here. We'll make sure that we share the webinar that was put up on the screen a few slides ago, the patient safety and women services, the action webinar. We'll share that along with the recording link today. We'd also love to share anything that you have, Dr. Miller, with regards to billing for services, and mentioning that some of the laws have changed in Illinois. If there's anything that you have there that you might be willing to share with us, I think that would be helpful to share, perhaps even with those outside of Illinois, just as a starting point. We, 2020 Mom, also have a page on our website that allows those providers who are trying to bill these services to report any denials, and we're willing to help step in and work through those denials with you. We know that this is a big issue for sustaining programs and effectiveness. So again, congratulations to you, Dr. Miller, for not only creating an incredible program that really can be scaled and that will be evidence-based. We're really looking forward to seeing your research. But congratulations on also being recognized by the panel of judges with the Innovation Awards program at 2020 Mom for your excellence in this program. We really appreciate all you're doing in lifting up this model for others to adopt. And those of you who are interested in following the additional programs that have received awards this year, you're welcome to register for any of the other webinars that you see up on the screen. There they are again now. They're coming up shortly, and we'd love to have you join us. You can find the path to the program at 2020mom.org/innovation-awards. One final shout out is that we want to recognize the funder of this program, the Zoma Foundation based in Denver, who's interested in lifting up best practices in maternal mental health, not only for their population in the 5-county area they serve in Colorado, but in the U.S. as well. So thank you, Zoma Foundation, for making this program possible. And thank you again, Dr. Miller, for joining us today, and all of you for joining us online. We appreciate it, and we will be in touch. Thanks, Dr. Miller.
Thank you. Take care.